Alterations in reproduction, disorders of the female reproductive system. Premenstrual syndrome is a group of physical and emotional symptoms that occur in some women prior to menstruation. It usually occurs 7 to 10 days before menstruation with an unknown cause. However, there's a possible hormonal connection, such as too much estrogen or not enough progesterone, and their effect on the brain. These women have physical and emotional symptoms. Different foods and drinks can potentially enhance some of these symptoms, such as sugar, salt, caffeine, and alcohol. Symptoms do include weight gain, headache, pain, irritability, personality changes, and anxiety. Menstrual diary will aid in diagnosis, but the classic finding is the client is symptom-free between menstruation and ovulation. Treatment will depend on symptom severity, will encourage healthful lifestyle changes, and potentially hormonal therapy. So true or false? The cause of PMS is hormones. And this is false because the cause is unknown. Dysmenorrhea is painful menstruation. Primary will be idiopathic, where there's no abnormalities found, and secondary is the result of another disorder. Symptoms include low abdominal pain and cramping. Treatment includes non-narcotic analgesics, heat, treating the underlying cause, or retroversion of the uterus. Other various menstrual disorders include amenorrhea, which is the absence of menstrual flow. Primary amenorrhea is the period of time before menarche, which is the very first menstrual period. Secondary amenorrhea occurs during pregnancy, after menopause, or removal of the uterus and or ovaries surgically, or at times during lactation. Oligomenorrhea is infrequent menses, which is normal for adolescent girls until menstruation is well established. Causes will include endocrine imbalances, stress, poor nutrition, or a lean body mass. Associated conditions with oligomenorrhea is polycystic ovarian syndrome or premature ovarian failure. In premature ovarian failure, this is the cessation of ovarian function in women that are younger than 40 years of age. It is when the body does not respond to the follicular stimulating hormone, or it can be an autoimmune attack, and it is diagnosed by a high FSH level. Polycystic ovarian syndrome is where multiple fluid-filled cysts are found in the ovarian follicles due to an imbalance of hormones. And this can cause infrequent or irregular menses and a failure to become pregnant. It is associated with obesity, insulin resistance, hypertension, and abnormal lipid levels. Treatment will include oral contraceptives and potentially surgery. Menorrhagia is excessive menstrual bleeding or menstruation that lasts longer than 7 days. It can be caused by endocrine or coagulation disorders. Medically and surgically, we use NSAIDs, hormones, endometrial ablation, a uterine balloon therapy, and photodynamic therapy. And menorrhagia is an unexpected, irregular bleeding outside the normal menstrual period. It can be found intermenstrual or postcoital bleeding, which is after sexual intercourse. We do consider spotting during ovulation to be pretty normal occurrence. Causes include a pituitary or ovarian stimulation, uterine malignancies, and cervical irritation. And we also may see breakthrough bleeding with hormone replacement therapy. However, this is considered abnormal and it does require evaluation. So true or false? Menorrhagia is a disorder where menstruation will last for longer than 7 days. And this is true. Menopause is the cessation of the menstrual cycle. It can be physiological or a surgical menopause. The climacteric period is the time in which the ovarian function will gradually begin to cease. Postmenopausal period will begin 1 year after menstruation ceases. Surgical menopause is the removal of the uterus and/or the ovaries. It usually will occur in women that are 45 to 55 years of age. So with this issue, we see diminishing ovarian function, a reduction in hormones. A hypothalamic pituitary stimulation will attempt to keep these cycles going for a period of time. These women will experience menstrual irregularities. In other words, they may not be regular, they may be heavy, they may be very light. They may have alterations in temperature regulation, sleep disturbances, mood changes, a diminished libido and/or pain during intercourse, vaginal wall thinning, breast and uterine atrophy, and a loss of bone density. We treat it with hormone replacement therapy, antidepressants, biphosphonates, symptomatic relief, and calcium and vitamin D supplements. There are risks with hormonal replacement such as strokes, endometrial cancer, blood clots, dementia, gallbladder disease, breast cancer, myocardial infarction. So the decision to use hormonal replacement therapy is made on an individual basis. Its use has decreased in recent years due to these potential complications. Nurses will encourage lotions for skin dryness and vaginal lubricants for intercourse. Exercise programs, education will also be provided on increasing calcium in their diet. And when should they call the physician? Vaginitis is very simply vaginal inflammation. It can be caused by chemical or mechanical irritants, pathogenic microorganisms, or predisposing factors such as age, unregulated diabetes, and hormonal contraceptives. These women experience abnormal vaginal discharge, itching, burning, and redness. We treat it with anti-infective agents. We also need to treat the sexual partner, symptomatic relief measures, hormonal replacements, and if the client is diabetic, we need to encourage good glucose control. Nurses teach that there should be no douching prior to the examination. Education on vaginal medications, in other words, administering cream or vaginal tablets high into the vaginal canal and instructing the client to remain recumbent for 10 to 15 minutes, or we administer it at bedtime. This helps make sure that the medication stays where it needs to stay. We also may teach douching with diluted vinegar, sitz baths, and education on prevention to include appropriate wiping techniques, the wearing of cotton underwear because it breathes better, hand hygiene, changing vaginal pads prior to saturation, and avoiding intercourse if the partner is symptomatic. Cervicitis is inflammation of the cervix, and it involves trauma from a gynecological procedure or infection, maybe due to decreased estrogen levels, and chronic cervicitis can lead to infertility. These clients may be asymptomatic in the early stages. They may have a history of spotting or unusual bleeding. They may have some dyspareunia, which is painful sexual intercourse, or an unhealthy vaginal discharge. Medical management includes antibiotics, douching, electrocautery, or conization. Nursing management includes scheduling procedures 5 to 8 days after menstruation and providing post-procedure instructions. Pelvic inflammatory disease, or PID, is an infection of the pelvic organs except the uterus. We see microorganisms that have entered through the cervix, usually caused from bacteria, and these clients may also develop a pelvic abscess or peritonitis. They experience a malodorous vaginal discharge, severe abdominal or pelvic pain, fever, menorrhagia, dysmenorrhea, or urinary symptoms. They may require hospitalization with bed rest in addition to antibiotics and symptomatic relief measures. And if there is a pelvic abscess, they may require emergency surgery. Toxic shock syndrome is a type of septic shock. It is a life-threatening systemic reaction to toxins that are produced by some bacteria. It can occur in non-menstruating women and men that have postoperative infections. It's associated with superabsorbent tampons and internal contraceptives. We see a virulent bacteria production with no immunologic defense, and this allows the bacteria to grow unchecked. These clients will have a sudden onset of high fever, chills, myalgia, nausea, vomiting, diarrhea, hypotension, disorientation, headache, a rash on the palms of the hands and the body. They may require IV fluid administration, definitely IV antibiotic therapy, adrenergics, and oxygen. Nurses should monitor vital signs and the client's overall status and provide client teaching on preventative measures, such as using sanitary napkins or changing tampons frequently, good hand hygiene, removal of vaginal devices within 24 hours after use. Endometriosis is a condition in which the endometrial tissue is found outside the uterus, such as the ovaries and pelvic or abdominal cavities. The pathophysiology and etiology is not clearly understood, but we do know that this endometrial tissue responds to hormones just as it does within the uterus, and it causes bleeding when that uterine endometrium sheds and bleeds, and this causes abdominal pain, and it results in adhesions and sterility. These clients have severe dysmenorrhea, copious menstrual bleeding, or chocolate cyst formation. These clients may undergo a natural or surgical menopause. We may need to remove cysts, or they may require hormonal contraceptives. Nurses will help with pain relief methods, provide disease and treatment education, and emotional support. Vaginal fistulas are unnatural openings between structures, and there's different types. We can have the uterovaginal, which is between a ureter and vagina, vesicovaginal, which is between the bladder and the vagina, a rectovaginal, which is between the rectum and vagina, and there are other kinds. These are the most common. These clients, excuse me, the fistula may have come about because of cancer or a surgical injury, radiation therapy, or a congenital anomaly, or Crohn's complication. Basically, there's going to be leakage of urine or stool through the vagina. We treat with surgery or symptomatic relief measures. Preoperatively, nurses will provide antibiotics, encourage a low residue light diet, do an enema prior to surgery, monitor or do a vaginal irrigation, or insert an indwelling urinary catheter. Postoperatively, we're going to monitor for vaginal drainage, keep the urinary catheter bag volume low to help prevent any backup, perineal irrigations, douches, and stool softeners. Pelvic organ prolapse is going to be the protrusion of a structure. A cystocele is the bulging of the bladder into the vagina. A rectocele is the bulging of the rectum into the vagina. This happens because of a weakness in muscles, often due to childbirth or in the fascia. There will be urinary and bowel alterations. These clients will experience stress incontinence, especially with the cystocele. They may have cystitis, constipation with the rectocele, or feel that something is dropping out with the ureterovaginal prolapse, where the uterus is actually protruding. We can treat it with a pessary, which is a firm donut-shaped or ring device that might be inserted into the upper vagina to reposition or give support to the uterus when surgery can't be done or the client declines surgery. We can also teach Kegel exercises and perform transvaginal repairs. Nurses need to provide client education on pessary insertion and care, when to call the healthcare provider, teach the knee-chest position, and teach the client to avoid heavy lifting. So true or false? It is common to use a pessary as treatment for a rectocele. And this is false. Uterine displacement is an abnormal position of the normal 45-degree anteriorly flexed position. With retroversion, the uterus will tilt backward, while with retroflexion, the uterus folds backward on itself. It can cause infertility. With anteversion, the uterus is tilted forward at a sharper angle to the vagina, while in antiflexion, the uterus, while bending forward, begins to fold over on itself. This is usually a congenital, childbearing, or scar tissue formation from PID problem. It can also happen from endometriosis. These clients experience backache, painful sexual intercourse, or dysmenorrhea. We manage with a pessary and encourage the client to get into the knee-chest position for periods of time. We assess for complications, provide client education on procedures and treatments. The uterine leioma is a benign growth of smooth muscle, fibrous connective tissue, and it's most common in the pelvis. We also call this fibroid tumors. The growth is stimulated by estrogen. There is a slow growth, and it can be located in various sites in the uterus. These clients are usually asymptomatic, but menorrhagia, which is most common symptom in those that do have symptoms, they may also experience anemia or dysmenorrhea, and that tumor size will shrink after menopause, because remember, it is stimulated by estrogen. We treat it by performing pelvic exams 2 to 3 times a year, doing a pap smear on a yearly basis, performing a D&C, a myomectomy, which would be the removal of the tumor only, or a hysterectomy. Nurses need to provide appropriate client education. Cervical and endometrial cancers probably begin as pre-malignant lesions that later undergo malignant changes. The localized malignancy is referred to as carcinoma in situ. Untreated, it subsequently will invade other areas of the uterus and adjacent tissues. With cervical cancer, this is the second most common female reproductive cancer, and it's most common in women that are 25 to 50 years of age. Cancer of the endometrium affects the lining of the uterus and is more common in postmenopausal women. Risk factors will include those women who experienced early menarche, a late menopause, nulliparity, which is no pregnancies, and obesity. These clients may have had a DES exposure, early and high-risk sexual activity, an HPV infection, smoking, or pelvic radiation. Bleeding would be an early symptom, and pain and pressure on the bladder would be late symptoms. We treat depending on tumor staging, and this may include hysterectomy and chemotherapy. Nurses should encourage the HPV vaccine, regular pelvic exams, and pap smears. Ovarian cysts and benign ovarian tumors are cysts that are composed of a membranous sac that's filled with fluid, cells, or both. And the tumors are non-cancerous growths of solid tissue. There is an unknown etiology, however, an endocrine dysfunction is implicated. It does affect menstruation and fertility. These women may experience menstrual irregularities, pain, lower abdominal discomfort, and backache. Treatment will range from no treatment to oral contraceptives to surgery. Nursing management is involved with pain relief, client education on surgery and postoperative cares, and the continuance of regular pelvic exams and pap smears. Ovarian cancer is the leading cause of death from gynecologic malignancies, as they're usually well advanced when they're discovered. They are hereditary. We do find them in nulliparous women, in other words, women who have had no pregnancies, and other types of female reproductive cancers. In the early stages, these women may just experience a vague abdominal discomfort or urinary frequency, and the later stages of the cancer, they may have ascites, weight loss, or severe pain. These women can be treated with a variety of surgeries, including an oophorectomy, which is just removal of the ovary, followed by chemotherapy. Nurses need to encourage preventative measures for the high-risk clients to include at least 2 pregnancies, breastfeeding, and oral contraceptive use for over 5 years. Vaginal cancer is rare, and it usually occurs in women that are older than 40 years of age. These women may have had an HPV infection, sexually transmitted infections, or unhygienic pessary use, along with DES exposure. They experience abnormal vaginal bleeding and pain with intercourse. We treat based on the tumor extent, but it can include laser photovaporization treatments, a total vaginectomy, or radiotherapy. We try and keep the client comfortable, control any odors, encourage lubricant prior to sexual intercourse, and also encourage regular pelvic exams. Vulvar cancer is relatively rare also, and it usually occurs in women that are over 60 years of age. There is also an increased risk with HPV and herpes. It is highly curable. These clients will experience pruritus, genital burning, a white raised labial patch, bloody discharge, enlarged lymph nodes, vulvar ulceration, or mass development. Treatment would involve a vulvectomy or laser photovaporization. And a hysterectomy is the removal of the uterus and the cervix, and it may include all or part of other reproductive and pelvic structures. The extent and approach of the surgery will be dependent on the pathology and the client's condition. The vaginal approach has fewer complications, a reduced recovery time, and of course a lower cost. Laparoscopically assisted vaginal hysterectomy is a combination of surgical and endoscopic techniques, and it's being used to perform vaginal hysterectomies that otherwise would have been performed abdominally. Preoperative care would include douching, placement of an indwelling urinary catheter. This keeps the bladder drained so there's less risk of puncture of the bladder during surgery, and antibiotics. And then we provide general postoperative care. Client teaching includes taking medications as directed, avoiding lifting and douching and intercourse until it's okayed by the healthcare provider, wound care, avoiding constipation and straining, and advising when to call the doctor.